Welcome, everyone. Thank you so much for joining us today. My name is Sina Haynes, and I am your Vice President for Professional Programming. It's a pleasure to have you joining this afternoon. It's afternoon now. Before we get started with our webinar, I wanted to share just a few opening remarks with you. This series has been developed in response to the needs of our NAP membership, which was identified through our needs assessment done back in 2017. Our session today is the first of a series of 3 unique and diverse interprofessional and collaborative care exemplars. This webinar and those that follow are being recorded and will be made available free to our NAP membership. All attendees have been placed in silent mode, so please ask any questions that should arise during this webinar into the chat feature inside Zoom, so I can field those questions as your moderator to our speaker as part of the Q&A process before concluding this webinar. I now have the pleasure of introducing our speaker, Dr. Bob Fifer, who is presenting on a pediatric interprofessional collaborative care model, its purpose, design, and application. Dr. Fifer has served on or directed interprofessional collaborative teams since 1984. He has been a member of teams that were highly successful, as well as teams with limited functional abilities. These observations, combined with his study of interprofessional interdisciplinary diagnostic teams, forms the basis underlying this presentation he's sharing with us today. As a faculty member of a federally designated university Center of Excellence in Developmental Disabilities, he has been responsible to contribute to the interprofessional education of students in numerous fields of study. This webinar will present 2 models of team collaboration for young toddlers and school-age children. Qualifications of team membership, their roles, responsibilities of each member will be highlighted toward the makeup of successful collaboration. I will now turn the presentation over to Dr. Fifer to continue. Thank you very much.
And thank you. And thank you all for attending. I'm glad to be with you today. The interprofessional collaborations take on many different models, and each model has its own unique characteristics. Depending upon the situation, the purpose of the team, and also what goals need to be achieved by each operational and functional model. The 2 models I'm going to talk about today are transdisciplinary and interdisciplinary teams in pediatric settings. Interdisciplinary I wanted to digress just for a second. Interdisciplinary is distinguished from multidisciplinary, although the terms are used interchangeably, as are many terms regarding interprofessional collaboration. But I want to really make clear that multidisciplinary is very much like children in parallel play. Each professional discipline who is there will do their own thing in terms of the evaluation, and they will come up with their own recommendations from the perspective of their particular discipline, not consulting or not combining results with other disciplines. That's in contrast to interdisciplinary, where each professional discipline will evaluate or perform an intervention function within the realm and scope of their respective disciplines. But they come together as a team for communication and put all of their observations and results together in order to create a whole person perspective of the patient. And so that's the difference between multi and interdisciplinary. Transdisciplinary is useful almost exclusively for infants and young toddlers, and perhaps is the most difficult type of team for you to be a member of. And the reason why you will see much more readily as we get into some of the requirements and the organization of a transdisciplinary team. Next slide, please. The transdisciplinary team concept came from a study that was sponsored by the United Cerebral Palsy organization back in 1976. So it's been around a long time. And basically, the motivation behind developing this type of a team construct focused on the fact that for children with cerebral palsy, young infants and young toddlers, you have all of about maybe 7 to 13, 14 minutes to get all the information that you're going to get. And once they reach that time limit and they are exhausted, you can stick a fork in them, they are done. And no matter how much you try to stimulate or activate them, there is just, no other valid response that you're going to obtain from them. And so as a result, the most appropriate use for a transdisciplinary team is when there exist extreme time limitations to obtain a valid response before fatigue sets in and starts to bias the outcomes that you observe. It's designed to reduce fragmentation in service evaluations, whereby you may have an OT, a PT, a speech-language pathologist, perhaps a developmental pediatrician, and preferably a parent present to observe what goes on in terms of the professional who is stimulating the child and the responses elicited from the child. Now, in this team concept, you may have professionals of various disciplinary backgrounds as team members, but the one primary characteristic of a transdisciplinary is that each member can assume fully the role of the other team members. So a speech-language pathologist can behave very much like an occupational therapist, OT can be a PT, PT can be an OT, etc., etc., in this transdisciplinary model. The implication from that is that someone who is fresh out of school, who has very little experience and who has very little exposure to other professional disciplines, probably would not be suitable to be a member of this team and expected to function independently. The different roles are, number one, facilitator, and the facilitator can be any of the team members except for the parent. The interactors may be some of the professional team members who, once the facilitator has elicited a response, a team member may reach forward to interact with the child for a moment or so to amplify that response in some way, or to delve into a slightly different realm into either self-help or social approach skills. And then the observers are all the rest of the team members who are not actively participating at that moment, and includes the parent. And the reason why the parent is important to be present during this type of evaluation, when it comes time to sit down and talk to the parent about what you, the professional, saw, it's a lot easier to go back and reference what the parent also saw. Next slide, please. One of the key elements of the transdisciplinary team is called role release. And that is you release your function, your role, realizing that there is a lot of scope of practice overlap among the different members of the team. And this is true universally, whether it's a transdisciplinary team or a single discipline team, that you come together in an interdisciplinary capacity. When the child is very young, the boundary in the scope of practice between speech and language and OT becomes very blurry, because their tools that they use to evaluate the child tend to overlap more with a very young child than they do with a slightly older child. The roles and the scope limits between an OT and a PT tend to blur. And so what this does is simply take advantage of that blurring and move it to a different level for the sake of team efficiency, the comprehensiveness, and making sure that the details are captured and discussed by the team immediately following the evaluation itself. Now, to be a member of this team, it is extremely important that your knowledge base as a professional includes a detailed understanding of your diagnostic tools, What does this test measure? Conversely, what does it not measure? And also, what part of the system are you measuring with each tool? And an SOP needs to know this about physical therapy diagnostics. PT needs to know this about speech and language diagnostics. And so there's a lot of intimate knowledge of the other disciplines that's really required for effective team function for a transdisciplinary team. Now, each member is interchangeable and can play the role of the facilitator / stimulator. And this is with the knowledge and understanding that blending the observations, you form a whole person perspective. And there has to be a collegial understanding and respect with regard to the complementary roles. This also means you have to be very mature in your professional understanding of what's going on, so that we can be very protective at times, but that protectiveness needs to disappear in this functional team model. Next slide, please. This is the evolution of the role of the individual for a transdisciplinary team. Starting at the top of the slide, you have role extension, which means increase your discipline-specific theoretical knowledge and clinical skill, because you really need to be awfully good at what you do as an entry point to understand what the others are going to do and how you complement them and how they complement you. Coming down to the right side, role enrichment, an awareness and understanding of the different disciplines, which means that you need to learn the language of each discipline. Speech-language pathology, psychology, PT, OT, developmental medicine, they all speak different languages or use similar terminology with a very different perspective. The illustration I like to use here is auditory processing. From the audiology perspective, auditory processing means when sound comes into the ear and begins to the decoding process going up through the brainstem, that's audiology auditory processing. We look for system overload and a breakdown in analysis function. Speech-language pathology looks at auditory processing with regard to what happens to the stimulus after it has arrived at the primary receiving centers higher up in the brain and gets farmed out for the association areas of the parietal lobe, frontal lobe, etc. And then psychology looks at auditory processing in terms of how do you use this auditory input information for executive function and decision making. The point being that different professions use the same terminology, but certainly without the same meaning. So the role enrichment is understanding not only what you are doing, but learning how to speak the language of the other disciplines as well. Role support is looking at supporting one another when the child's diagnostic situation becomes very complex, very complicated, not straightforward at all. It can be a little bit of this, it can be a little bit of that, and it's not at all uncommon for an infant or a young toddler to have different things going on in different functional domains that have to be teased out according to the eyes of the disciplines looking upon the child in order to develop a plan of intervention that's going to be precise and efficient and cost effective. Role expansion, pulling the ideas and exchange of information with regard to judgments in particular and recommendations from the different disciplinary perspectives. And role exchange occurs when team members have learned theories, methods, and procedures of the other disciplines. Once you get to that point, you are just about at the top of the mountain in terms of your ability to fully participate in a transdisciplinary team. And then the final step is role release there in the center. And that's when you have enough knowledge not only about your discipline, but the other disciplines involved in your team that you can assume for an infant or a toddler the role that they would play in the evaluation process for that child. Next slide, please. The different domains or the developmental areas that are typically evaluated for young children focus first on cognitive development, the physical development, language and speech development, psychosocial, and self-help skills. These are the primary domains that the infant-based and young toddler-based diagnostic tests are built around to look at each of these domains. The last symbol down there is that the team needs to function as extensions of one another so that you operate in a cohesive, collaborative unit that is one unit, not a bunch of individuals doing their own thing. And so the key to all of this is the conference, the communication. An audiologist will see the world through the eyes of an audiologist, an SLP through the eyes of an SLP, PT, OT, they see the world through their eyes. And so in some situations, they're looking at the child and they're seeing the same thing that the others are seeing, but with a different interpretation. And when they come together for their team conference, when this is all done, then they can really put together all of their thoughts and perspectives to create the whole person concept for that infant or toddler. Communication is the key here, and I'll come back to that again later. Next slide. Interdisciplinary is where you have multiple professional disciplines acting independently to do their thing for each child and then come together. Now, a couple interesting things about interdisciplinary that we have learned through the ages. Number one, it is important for each discipline to take their own history from the parent. And here's what we learned. A parent is going to tell an audiologist what they think the audiologist wants or needs to hear. They're going to tell an SLP or a physician or a PT or OT what they think that professional discipline a representative needs or wants to hear. It isn't so much that they're hiding something, they're responding to the context of the situation. And putting together the history through the team members can sometimes be just as essential, just as important as putting together the diagnostic test outcomes. Because once you have the full history, that lays the foundation from the family perspective on how to interpret what you have and also how to develop plans of intervention that are appropriate but also family focused. I'll explain more about that in a moment. In the evaluation stage of what goes on, each discipline reaches a preliminary conclusion of their test findings, but the final diagnosis is deferred. And the reason why is because your interpretation of your diagnostic findings sometimes may well depend upon the outcome and interpretation of other diagnostic findings. Auditory processing from the audiology perspective is a prime example. If I find a child with an auditory processing delay or disorder, then, well, coming back to neuroscience, one of the basic principles, every part of the brain is connected to every other part of the brain. And so if you find an issue with one domain, you may find issues in other domains as well. And so you need to see what's going on, because what someone else finds and their recommendations for intervention may take care of by default what you would have recommended. The test results sometimes will show subtle abnormalities in several domains. For example, we had a child come in years ago. The parents took the child to a speech pathologist. Speech pathologist said, "I know what's wrong. Do this, 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 and this, and your child will get well." Well, they did that, and the child got better, but not well. Sometime later, they took the child to a physical therapist, and then later an occupational therapist, and later a psychologist. And each time it was, "Oh, I know what's wrong. Do this, this, and this, and this, your child will get well." Well, things improved, but never got better. Never got well. When we could see the child as a complete team on the same date of service, and we sat there and we talked to each other, we discovered that this child had an abnormality in this domain that was defeating what was being done to provide intervention in this domain. And it was going all around where one domain was defeating the therapy for another domain. Only when we can come together to create a whole person picture could we see that this is the dominant thing, but we have to pay attention to this over here, and et cetera, et cetera. And so the recommendations that we came forward with were in priority structure, taking in mind that the type of intervention had to include acknowledgement that you have multiple domain issues with this particular child. The holistic image of the child can be very cost-effective and very appropriate to make sure that the intervention itself is more cost-effective. Next slide. The personnel characteristics is that each member needs to be experienced and well-grounded in his or her discipline to know what your test is measuring, and just like with the transdisciplinary, what part of the system are you looking at, and conversely, what part of the system are you not looking at. You also have to know how to play nice in the sandbox and not be threatened by some degree of overlap from another discipline. Speech path and psychology overlap quite a bit, but they can also complement each other through that overlap. You have to be flexible. If you're going to be family-centered, patient-centered, you're going to have to be flexible in meeting the needs of the parents, the patients, and the other team members. And all members are on equal standing without the king or queen or dictator of the team. As was mentioned in the introduction, I served on a team in another life, another place, where there was a queen dictator, not just a queen, but a queen dictator of the team. And she controlled who said what and when and what order, and so there was no free exchange. There was no true interaction among the team members. And all the seats were assigned, believe it or not. And if you sat in the wrong seat, heaven help you. And if you spoke out of turn, heaven help you. And that doesn't work. The team members have to be on equal standing, and each one is capable of leading the team. And there are times when that does have to happen, just because of logistics or illness or whatever. But they must be on equal standing, and the atmosphere of the team must be such that the communication among each team member is free and complete and without any sense of being threatened. It also has to have a very mature attitude and outlook, even when looking at the same thing through different eyes, because what's being revealed is complementary information, not competing information. Next slide. This is one that I came up with the help of Dr. Chris Johnson, who is a developmental pediatrician in San Antonio. Back in my early life in the military, we had interdisciplinary teams back in the mid-'80s when many places had never heard of it. This is an easy, hard diagram. In the first block, you have thyroid disease, which is easy to discover and diagnose. It's also very easy to treat. Behavioral and learning problems can be very difficult to diagnose, but once you know what you're dealing with, then they can be pretty straightforward to treat. Down in the lower left, Down syndrome, spina bifida, very easy to diagnose. You can see them coming quite literally, but they are also very complicated and very difficult to treat and to provide ongoing effective intervention. And last, in the bottom right, autism and cerebral palsy are hard to diagnose, and they're also hard to treat, in part because they don't appear until the child is anywhere from 15 months of age plus, and there can be a lot of dynamics associated with them in such a way that you've got to really bring in a team concept to fully evaluate what's going on and develop your plan around that. Within this diagram, everything except the thyroid disease is very appropriate for an interdisciplinary team. It does not mean that all the team members remain part of the active team as time goes on, because they can be triaged out depending upon if their role is very minimal or not necessary. But the behavioral learning, autism, CP, Down syndrome, spina bifida, all of those diagnoses are very appropriate as examples for an interdisciplinary team. Next slide. Again, the characteristics, your goals that you're shooting for is to provide complementary perspectives for a complete picture, the whole person concept of the patient, to allow overlap of intake histories to get a more complete picture of what's going on, and to understand the overlap of test paradigms for complementary professional activities. And then understand the terminology of the other disciplines, learn how to speak their language. In order to make this work, next slide please. In order to make this work, there has to be ongoing communication between the team members, effective communication. Without that, the team is not going to work. When there is communication, then you begin to have cost efficiency for complicated or complex diagnostic situations. Any one of the team members can be a point of entry into the healthcare system for access to an interdisciplinary environment. And the team itself is most effective for certain diagnostic categories. It's not effective universally. But when you have something that, you know, we've heard the term funny looking kid that we use only among ourselves, never to a parent. Well, meaning that you see this kid, you know something's wrong, but the child does not drop into any diagnostic category cleanly. That takes a diagnostic team to try to figure out what's wrong, because you see a little bit of this and a little bit of that. And the last element, in order to make this cost effective, there has to be effective triage for follow-up management and intervention. If the initial evaluation required, for example, 7 different disciplines, then your follow-up may require only 1 or 2. And so that effective triage is really what you focus on for the primary things that are much longer lasting. Next slide, please. The primary concerns on putting any team together, whether it be a trans or interdisciplinary team, is number 1, inappropriate team members. These are individuals whose egos they know no bounds. Team members who are very defensive in terms of scope of practice, very jealous, very protective of their scope of practice, and team members that tend to dominate the others, walk all over the others in putting their knowledge, their expertise first and foremost. The lack of intimate knowledge regarding test paradigms is a drawback. That means that the individual may not be totally inappropriate someday, but may be inappropriate at the present day as a member of that team. And then one of the drawbacks of a team is to really focus on what does the child need, as opposed to what can the child do. In our team settings, we learn to emphasize, by virtue of parental input to us, we learn to emphasize the child's abilities as well as the child's disabilities. And time and again, we've had parents come up to us and say, "Oh, I'm so glad that you found something good about my child. I've had my child seen by many different professionals, and they only focus on what's wrong, as if my child can't do anything right. Thank you for finding something good about my child." And this brings us as a good segue to the next slide. The family is a constant in the child's life. You and I come and go. We are there in that child's life just for a moment, like the morning mist, and then we're gone in terms of the perspective of time. But the family is the constant. And so we have to be able to be family focused. That means that the team has to elevate the family to become a full decision-making partner in all that transpires with that child. We need to offer complete and unbiased information with regard to the child's status, as well as the child's abilities. We need to honor and respect diversity, strengths, and individuality. And almost invariably, if you live in a multicultural situation like we do here in Miami, you're going to see things that you were not prepared for. We had a child come into us one time The child had seizures, and our pediatrician on the team prescribed an anti-seizure medication. Mother went home, came back, and our recommendation about 9 months later for a reevaluation to see how the child was progressing. The child was seizing just as bad that day as the child was on day one. And mother swore up and down that she was faithful about giving the child this anti-seizure medication. Someone on the team had the brilliant idea of suggesting, how do you administer the medication? Now, the mother was from Haiti, and in Haiti, Western medicine is available, but they also have great faith in witch doctors. And the witch doctor had advised the mother, and we have witch doctors in the Haiti community here in Miami. The witch doctor had advised the mother to break the capsule, make a compote of it in a little cup of water, and rub it on the child's arm. That's how the mother was administering the medication. She was being faithful, but there was a problem there. And so once we were able to see that and provide guidance to her on the appropriate way, the child became better. Lastly, parents, many of the parents that we serve with a special needs child can be overwhelmed by the necessities of life, especially if they live in a metropolitan area or if they live way out in the country where they have to drive long distances for services. The team has to prioritize the recommendations as to what's most important to be done now, what can wait a while and become done second and third and fourth and fifth and so forth. You have to prioritize according to the family's abilities, their limitations, and also their priorities for the child. The family has to be a full partner in all of this to make a transdisciplinary team work or to make an interdisciplinary team work, or if you are a single discipline seeing a child, to make that single discipline evaluation work and to be effective in what you do to the child and for the child. And with that, I will pause and entertain any questions that you have.
So if anyone has questions that you want to submit into the Zoom webinar chat box, please do so now. While I'm giving you a moment to do that, let me go ahead and share, as you're seeing on your screen, that we have 2 other webinars that will be coming up, and so stay tuned for that. The first will be the Midwest Interprofessional Practice Education and Research Center Collaborative Practice Model presentation on May 20th, and then Building a Culture for Interprofessional Collaborative Practice in Oral Health. That will be on June 3rd. We'll be sending out further announcements and reminders about that. Those will also be recorded and made available. I also want to put a quick plug in to save the date to let you know that our 2020 annual meeting and forum is going to be in San Diego, if you're not aware as of yet. The dates will be March 12th through the 14th, and we hope to have you join and see you there. Well, Bob, I think you did such a thorough presentation. We don't have any questions at this time, but we want to thank everyone for joining, for visiting with us for this webinar, for Dr. Fifer for his wonderful presentation. And we will bid you adieu and wish you all a wonderful afternoon. And thanks again for joining us.